Thanks, James, and thanks to all of the panelists. I think, at one point we raised the question that there are some people who would have us think that the answer is either mental illness or guns or better health services or lock more people up. It's not either or. And I think what you've heard is that there are very exciting views of the future and what the future holds from each of these perspectives and in each of these areas. They're kind of bursting, they're kind of brimming with things that we can do to go forward. What I want to do two things. I want to ask the panelists if you have questions for any of your fellow panelists here. And this is a chance to ask them that question. And then I'm going to go around and I'm going to solicit from the rest of the forum and from all of you here in the audience one suggestion for going forward, one thing that you think we ought to do, one thing that you think is particularly important for getting towards this goal of no violence related to mental illness, either as perpetrators or victims. But we're going to come back and everyone's going to have a chance to contribute one suggestion, either in the research program or policy arena where we move. So let me first start and see if the panel has questions for fellow panelists about these other areas. Okay, we'll give you more of a chance later too, and you can respond to some things that came up. Let me go around and get some suggestions more, and I'm going to start with the forum members, but then we're going to include everyone here, and I'm going to ask someone to take good notes about this. Someone back there, Rachel, shaking her head. Okay, it's being transcribed. So make sure you are heard when you give your earth-shaking, most important area for change and improvement. But so we're going to start with you, Hendricks, and we'll go around first for forum members here.
Thanks, Mark. I have a request of you. There was a book that came out a number of years ago that has the title, the interesting title that says, How Superstition Won and Science Lost. And I think that the title of the book is better than the book. But there's a real message in there. And one of the themes in this one is that we really have lost the battle. I think it's indicative that you and your colleague, with the one who is dealing with the NRA, got edited out. And I think this is something about the process of coming together, as you had indicated before, is a really critical one. So I think one of the pieces is how do we shape the field so that we can have these collaborations? I would love to see that. I would love to see that on some web pages and put it out in blogs. How do you actually create this new stage of work where people do find mutual self-interest to be able to do that?
Well, thanks, Hendricks. How do we have real collaboration, and how do we bring together people who are politically opposed but who might work constructively towards a common shared goal? Thanks. Madeline?
Related to that, maybe an earlier, I think it's a shame something like this happens as infrequently as it does. And as science gets more specialized in its areas and the journals belong to certain areas, we don't share as much. And the more we share, the more we might find that things that were developed in one area apply to others and findings apply to others. And this joint collaboration, I think, needs to be part of the work, not just a special forum or workshop.
Thanks. Bridget?
Well, I wish I was actually on the other side of the room because I hadn't really thought about this question. One of the richnesses, One of the richnesses of this workshop is how thought-provoking it has been. I mean, they always are, but this one has been particularly so. My mind is thinking about this new term, therapeutic jurisprudence. I'm thinking about the lived experience. There's some new terms that are rolling around in my head that I don't feel like I've had a chance to digest, but since I live and breathe dissemination and implementation and think a lot about how do we stop doing things that don't work, how do we keep doing things that do work and expand them, and then how do we ask the kinds of questions that don't get us stuck in 3 to 4 years worth of sort of a procedure that doesn't yield us answers that then we can act on. I think I'm very interested in what the incentives are that we can have through policy to really move this work forward. So there I've covered about 3 or 4 different things, but thank you.
Thanks very much. Very good for being on that side. Michael.
I'm going to request 2 because I need to respond to Jim and then have my idea. Because Jim's talking about saying suicide with, suicide. I'm the guy who kind of pushed suicide as more important than interpersonal violence. So I think I need to respond to that a bit. It's been very hard being the squeaky wheel getting suicide on the agenda largely. And so one has to sort of sell what you got. And certainly in developing countries, suicide is a more common cause of death. I think in response to Jim, I agree it's really important to keep them together. Let's try and keep doing that in the forum, making sure that they do stay together. I think the causes are very similar. I think the interventions needed to prevent them are very similar, so I think that's really important. I do not agree that that interpersonal violence has more secondary outcomes than suicide. Just talk to parents who had a child who suicided, and for the rest of life, it's a very heavy burden that affects them quite dramatically. So I think that when you look at DALYs and other secondary outcomes, suicide will not necessarily be all that smaller than interpersonal violence. I think they do need to be together, and it isn't either or, just like it isn't mental health or violence, or we got to integrate as much as we can. My suggestion, things are very different in other cultures. I work in China, and the whole setting is completely different. And I think promoting like getting the idea of talking suicide and interpersonal violence together, unthinkable. It's just not going to happen for a long time. And so moving this forward in many developing countries requires, and I've mentioned this before in one of the previous forums, the development of methods for situation analysis, cross-cultural situation analysis. And it's not just sort of going there and looking how it's a bit different and playing. There is a science there of how you figure out what the factors are you need to know to start moving this issue forward, given what we're doing here in the United States and developed countries. And the kind of issues you need to know, who are the key stakeholders? They're very different. In India, I'm working in India and China now, and those 2 countries are very different. One's a democracy, and China is very different. Who writes the checks? Who makes the policy decisions? How are they made? What are the attitudes about community members, about mental illness, about violence, about the relationship, about suicide? Those attitudes kind of drive what will be supported and what won't be supported. What's the role of science in kind of making policy? And science, is it a small actor, a big actor? How does it get its voice? How does it have a role in the policy implementation and the decision of how you allocate resources? How do you find and incentivize needed providers? I don't think we're ever going to have, in China, like I said, I have 173 million people with current mental illness. We have 20,000 psychiatrists, a couple of nurses, and no psychologists. That's it. And there's nobody else who's providing services. How do we find people who are willing to provide services? Because it's very low status stuff, providing service for mentally ill people, or for those who are violent in China, because it's a stigmatized thing. How do we find and incentivize people to provide those services? And that varies across culture. Then clearly we want to have other stakeholders involved. In different cultures, the way of engaging other stakeholders are different. How do you get the media to help you? Will the media be on your side or not? And that's cultural, and that's when you do your situation analysis, you got to know what are the mechanisms in this particular setting, and sometimes it will be divided and stay into region, but I'm thinking national now. How do you get other stakeholders? How do I get the police being interested in suicide, for example? how do you, we need to change attitudes. Changing attitudes in different cultures is done differently because they're starting from a different base. And so when you do a situation, when you do a situation analysis, there's all the variables you need to really understand before you have any idea of how you're going to move the issue forward. And I continue to believe that this is a science. We talk about translational science or adaptational, but this detailed situation analysis is a science that needs to be developed. We can't get it funded, but I think we really need to work on it if we want to have these programs really effectively implemented globally.
Thanks, Michael. A lot of food for thought, good food for thought. Fran.
I have found myself as a program implementer, creator, policy person with my work background, not a researcher, but struck during the time I was doing program work. A lot of what the content was involved in understanding the actions of sex offenders, and in particular would be asked many, many times by the media about the most dangerous sex offenders who were the most rare of the sex offenders, but created the most damage, the most number of victims. These were the people who people were most afraid of. I was struck so, with all of the years of that work, struck so by listening to so many of the presenters here talking about the tail and the highest risk people being also the fewest, but the most, perhaps the most dangerous or most subject to danger themselves, and thought, over the years, this is totally not from a researcher perspective, a program perspective, I thought hard about it, and then I learned that the best answer I could give was for those high-risk individuals, because my program work was aimed at the middle of the tail, trying to reduce harm and do prevention with people who were in the largest number of offenders, creating had the fewest victims per offender. So I thought about that learning that I got from that program work in the context of this workshop, and thought there's a lot of similarity here. And what I learned to say to the media in particular was, for those highest risk people, and they're acting as adults in their offending behavior, the best I can suggest is that people have to reach them at a very young age. People have to introduce the interventions, they have to do the research, they have to understand how to get to these adults at a very young age. So I'm not saying give up on the high-risk individuals completely, don't offer them services, but I am saying in terms of the research, understand what are the absolute earliest stages that this kind of behavior asserts itself, address the behavior at that level, pay attention to programs at that level, and a generation from now, we will be dealing with a different population of sex offenders. And I kind of I still wonder whether that kind of approach for this group, for this subject, might be also relevant as a direction for researchers. Take all that we know about the middle of the tail and apply it to programs. But in terms of these highest risk people, we don't want to leave them off the radar. But maybe we need to address, turn our attention to the youngest children and understand those links between those early precursors of behavior.
Thanks, Fran. We heard several people, starting with Tom Insel, talk about pushing the curve back. And pushing back, he talked about finding young people with mental illness at earlier stages so that you could prevent some of the later sequelae. If you could prevent a young person from developing a psychotic episode, you might save them tremendous trauma and improve the quality of their life, their family, and their community. But we've heard several people talking about pushing that curve back and the big hump. If we can move it back and do things on a population basis, we could have a big impact. Thanks for bringing that part up. Yes.
So, I completely would. I completely would agree. I think there's very interesting things with respect to trauma, where if the trauma occurs really early in life, the effects go throughout the lifespan. So obviously, if you could deal with the trauma experience or even remove the trauma experience in that early case, you really are dealing with a totally different developing individual. And the same is going to be for some of these other factors as well. So I completely and utterly agree. The only thing I would want to reiterate was the fact that, we do know that, a patient with PTSD in adulthood is addressable with techniques that are available. We do see changes in the brain following a successful intervention in those patients. And I know work with adults with ADHD who have not been appropriately, treated beforehand, who are receiving treatment in adults, where you're also seeing brain level changes consistent with the behavioral improvements that they're showing. So it's just, again, I know you weren't really saying don't do anything, but just to say that you really can do something, even if clearly, and I completely and utterly agree, catching the individual at the earliest age would be the best way to go.
Thanks, James. Laura?
Yeah, my name's Laura Mosqueda. I'm a family physician and geriatrician at University of California, Irvine. So I'm going to take advantage because I think you asked us to say one thing, but it sounds like we're allowed to say a couple more. So as long as you don't come
I'm sorry
after
that
me.
you announced your intention ahead of time, but I think if we want to get around, we better limit it.
I will keep it brief. So if I had to say just one thing, it would be implement what we know works, period. Because there's so many things we know. I mean, it was really frustrating to sit here today, and also my experience as somebody who not only does research and teaching, but sees patients, is somehow we keep missing that. And no matter what kind of meeting, no matter what kind of topic I go to, that's the recurrent theme. Whether you're talking about family violence or alcoholism or issues related to the prison system, et cetera. And in fact, we even heard today that we implement things that we know don't work instead. So I think that's something that needs to get pursued. We have to make the right thing to do, the easiest thing to do, clearly. And we have to stop arguing over who's worse off, because then we end up arguing over the resources, and we're just starving dogs fighting over the one bone. This idea that treatment might be the same as primary prevention is really exciting. The idea that if we can treat kids who've been victims of abuse, and we might end up in primary prevention related to domestic violence and elder mistreatment, is something that can bring us together rather than split us apart. It just strikes me that if some of the ideas we heard about today were a new pharmaceutical, they'd be marketing and they'd be blockbuster drugs. And we might want to consider why that's the case. And finally, I would say at some point we need to confront head-on the issue of responsibility. We touched on it briefly today. Whether or not alcohol leads to violence, does that make it an excuse for violence? The concern about that idea. But at some point, and I relate this very much to issues in the field of elder abuse, where we talk about caregiver stress, where people in the domestic violence community say if you talk about it as caregiver stress, you're blaming the victim. But we have to at some point make a distinction between explanation and understanding is not the same thing as an excuse. And the more we understand about psychopharmacology, and the more people are marketing things like the no-lie MRI, which you can look up on the web, we're going to have to really confront this in a solid, well-founded scientific way.
Thanks, Laura. Kathy?
All right, I think that the one thing I'd like to say is that we need to consider the stress and distress, and that's something that Vicki mentioned, and I don't see that as an excuse for the violence or for being a victim, but I think that given the number of people in developing countries who are committing suicide, who are involved in violence or victims of it, and the stress that they are seeing, that's something that really has to be taken into account. It's among the roots of some of this. And the statistics that Michael gave about suicide in other places, and if you looked at it in Asia and Africa and the Middle East, female suicide was a lot higher than male suicide. And you see the stress that they're under, the abuse that they take often at home, and the fact that they are sometimes, in some countries, pressured into committing suicide. So I think that we need to look at those kinds of things as well as the treatment in in a way to understand what's going on, not as an excuse.
Thanks, Kathy. Peggy.
Okay, first, I do want to say something about the fact that the Planning Committee did discuss, Jim, what you brought up, the angle of the mental illness that's the result of witnessing violence. We did talk about it, and many of the Planning Committee wanted to include it in the meeting. Of course, we had to make some big decisions about what we could fit, and we did address this issue in the report that the forum did on the contagion of violence. And while we can't do, probably didn't do 100% justice to it there, we did feel like we had to kind of make some decisions. So it's an important issue, and I'm glad you raised it again so that we could be reminded of the fact that it is an extremely it's an extremely critical area, but we felt like the forum as a whole had already started to address it in that earlier workshop on contagion, and that's why we didn't specifically bring it up this time. So I'm sort of defending the committee, just to let you know that it was discussed, that the committee did bring it up. They did feel it was an important area.
It wasn't a criticism. It was simply to.
Okay, good. But I just wanted to give the committee credit for bringing it up. Sheldon, you mentioned that you wish we had an intervention to deal with fear. And that's really important. And I was thinking of what, James presented in terms of the neurobiology of aggression and why people choose or make the decision to do a violent act. And I was going to ask James, how close are we? I mean, fear is kind of a general area, but fear is behind a lot of the decisions to do something. Certainly in these cases we've seen with the stand your ground laws, where someone just, shot someone and killed them, it was fear that was the motivating factor. And, our brains evolved to be fearful. It's an important protection for us as humans. And I'm wondering, James, could we create interventions that deal with fear in a general way, or do we have to make them more specific? How far are we from knowing enough about the biology to design interventions?
No, we're there. I mean, that part, if anything, is the best that we're at. So we know with PTSD, you can use CBT that will indeed take individuals' threat sensitivity down, and you'll see the change. The amygdala responsiveness to threat stimuli will be reduced, and in those individuals where it is reduced, those are the individuals who are also showing the nice benefit from intervention. We haven't categorically demonstrated that in a violent population yet. That's something I'm hoping that we'll be doing, or others will be doing in the next couple of years. But I think that with that, for that sort of reactive, rage-based stuff, we're ready.
But what I was wondering is if the intervention designed for PTSD, the CBT, does that reduce fear in general, or just specifically?
Oh no,
sorry,
it reduces. I mean, PTSD itself, you get obviously the trauma is the big thing, but you get a lot of generalization to other, so a loud noise going on. One patient that we had, a car beeped just behind her, and she smashed the car and chased the car down the road. And the beep was nothing to do with the trauma; it was just another stress stimulus that came in, and this response. You get a lot of generalization. Even the fact that you're showing, one of the biggest probes is fear expressions for amygdala responsiveness. That's typically not part of most people's trauma history, but it's a very good probe of the responsiveness of the circuitry, and you can see that responsiveness to this non-trauma related stimulus going down in those individuals who are successfully treated. So yes, indeed, completely. That part, I think. I mean, again, we have not demonstrated that at a biological level in patients with aggression who are being successfully intervened with. But we do know that that population seems to be the most receptive to intervention, and the interventions are very similar to the PTSD CPT type interventions. So in theory, that's what we should be seeing, but we haven't documented it yet. But I really think either my group or other groups that presumably are working on this will be documenting that in the next couple of years.
Thanks, James. Thanks, Peggy. A quick comment from Shelley before we go around.
Very brief. I also wanted to include in that a focus on, maybe the forum wants to take this on, the contagion of fear as it relates to neighborhoods and communities, particularly around this issue. Look at what we've done in regard to fear relevant to violence in schools. It follows communicable disease perfectly. and someone needs to take that on.
Thanks. Kimberly, did you want to comment?
I would like to advocate and push, being a program evaluation nerd, that we really sort of focus more on program evaluation and using and looking at using fit for purpose design, and recognizing across all of the stakeholders that what we might be interested in terms of design intervention, effectiveness, outcomes and accountability may be different of what we need for policy evaluation, but also that usually one design does not fit all of the needs and answer all of the questions. So if we can really focus on adapting evaluation design that's really fit for purpose and understanding what that purpose is, with good application, we can do some rigorous evaluation and be able to move the needle forward.
Thanks. Rachel, is there anything you wanted to add?
Yeah, I would just say that when we as the staff were when we were challenged by the forum members to organize a workshop around this topic, we very quickly recognized all of the complexities and the multiple pieces that were involved. And it seemed very challenging how we were going to pull this together into a 2-day workshop. And I think that was quickly shown when we were pulling together the planning committee and all of the different perspectives and stakeholders that we needed represented within that group. And it shows we ended up with a committee of 10, which is much larger than what our planning groups usually are. But all of those perspectives that were represented were seen as extremely necessary to have there at the table. So I think there's been some talk, and we've heard some comments about in this workshop and the different sectors and perspectives that have been brought together and sort of the meaning of that. But I also just wanted to give recognition that this is the result of a group of 10 people from very different perspectives in very different sectors coming together and grappling with these issues over the course of several months. And this is the result that we came up with. So it's, I think, a little something to think about as far as collaboration going forward.
Thanks, Rachel. Jackie?
I have one question that Dr. Blair can answer with a yes or no, and then I have one thing to say. So, Dr. Blair, was the research you were talking about that showed the effect on the neurobiology with adults or children?
Answer that, please, with a yes or no.
Oh,
He said
all right.
yes.
Was it
He
with-
said yes, Jackie.
Was it with children?
It was with adults, the study I'm particularly thinking about.
That's
I mean,
what
I have
No, no.
no dangers about it being
Yeah,
shown in kids
right.
as well, but it was
Because I just know that a lot of people, can we heal
oh no, that indeed.
the issues for children's brains, which goes back to what Jim was saying. And the thing I have to say is this. One of the things I think is incredibly important is to, as I said before, both attend to individual children, youth at risk, and develop interventions for them. But it's incredibly important that we persuade the public to invest in then disseminating those interventions that work. And I'm thinking of Judy Bass's intervention. I wish she was here to talk for herself. But I've done some work in the Congo too, which is where she tested this intervention. And of course, the hope of it is that they were able to teach health workers how to do this. The only problem is that there's no policy initiative in the Congo to scale this up. And it was not done with governmental buy-in at all. And nobody's going to do this intervention now that the NIH money is gone. So, and that happens a lot. And so, yeah, and I go back to what Tom said day one, persuading the public to be willing to invest in dissemination of these things that have been shown to work on relatively small scales, and that program evaluation we talked about that's rigorous.
Thanks, Jackie. Very short, because we have 20 minutes. I do want to make sure we get around here, and I want to give some of the other people who've stayed here a chance. So yes.
Great point. And I think that the answer to that is that we have to work with governments, national or local, but we have to work with, sometimes it's better to move slower, but in a sustainable way, rather than do big interventions that after a while remain in nothing.
Thanks, Devara. Shinshi?
Mark, what you didn't say is also that at the later stages of the queue, there's also, we have to think about saying something different than what my other colleagues have said already. At the risk of, I choose to paraphrase three of my colleagues, and I say that briefly. John Westphal from Colorado wrote a piece in JAM a few years ago back, and his title was Practice-Based Research, the Blue Highway, where he highlighted it takes average 17 years to implement 14% of the evidence into practice. It took us more than 25 years to implement beta blockers as a standard of care when the evidence first came out more than 30 years ago back. My colleague, Richard Franks, now at ASPE, previously at Harvard, he gave us a number of talks, and he's always said the curse of being academics, that you must submit research grants to NIH that is pure and sterile and randomized in a fashion that is not of the real world the majority of the time. And then you're asking policymakers to implement those evidence-based practice into a messy world. So he challenges with a question to say, is it better to devise a truly pure, sterile RCT in a virtual world, or is it better to conduct experiment that's 50% messy, but is much more implicable and ready in the real world? And the third of my colleague is my colleague Mary Tonetti at Yale, who I did a congressional policy fellowship with. She reminded us sometimes how little research is needed to form policy. And from her experience and my experience in the world of elder abuse, we passed legislations in the states on mental health issues and elder abuse in Illinois, often with evidence, often with very little evidence. And so to that note, my recommendation I wrote down as strategic, coordinated, unified, multi-level advocacy efforts. Thank you.
Thanks, Shinshi. I won't attempt to repeat that, but I like it. Elizabeth.
I really think an excellent workshop and bringing together many different perspectives to a useful end. But I think the challenge really is how are we, when we leave here, going to see that some of the things that we know work right now are being used at the policy level. And recently I did something which was to send our minister a 3-point plan to deal with a big issue that he was interested in. And you know what? He followed my advice. You understand me? Not long, not this. And I would say that all of us have our 3-point plan, that we can give them a good quick win. While we clarify what doesn't work, we can focus on what does work and what works within their policy framework. And, make sure that we do not sit with all this information that we have, and we try and move, as we say, the whole agenda forward.
Thanks. Arturo.
So I have been thinking about the father of epidemiology, Rudolf Virchow, who close to the 1850s said that medicine was a social science and that politics was nothing but medicine on a grand scale. And I think over these few days I have added to that public health should be policy at the global scale. And I think this global forum, and again I will push for the low and middle income country focus, this discussion over the last few days on mental health and violence has brought me full circle to the Universal Declaration of Human Rights, which more than 64 years ago, I think the spirit was correct. And I think also when WHO was created and trying to attain the highest level of attainable health and well-being was thought of properly. And this was more than 6 decades ago. And with all the instruments that followed, the International Covenants of Political and Civil Rights, the International Covenant on Cultural, Social, and Economic Rights, they all had the right spirit, no? So I think over the last few days we've discussed all this evidence that brings us back to the social determinants as the major risk factors for both ill mental health and violence, specifically issues such as income inequality and adverse early childhood experiences. And my recommendation, Mark, would be that I think we cannot remain blind to certain global systemic issues that have also been discussed here. And by these I refer to the macro elements, to the low-lying fruit, to where we could get the biggest bang for our buck. And this is alcohol and guns specifically. We know so much about them as risk factors for mental health, adverse outcomes, for violence, for injury, and in general. So I think we would need further thought on the role of diplomacy, on the role of international law and global trade and commerce to regulate these issues. It seems like common sense to me. It seems ridiculous that in the 2014, the year we're living in, the double standards should not be applying as they do across borders. It makes no sense. So my recommendation is to look seriously at these issues. And coming from the Violence Prevention Alliance meeting, which we were all, some of us part of in the Mexico meeting last November, I think the United Nations General Assembly will pick up the issue of violence prevention in their next round of talks. And I think similar to what happened in road safety, that this global movement of diplomacy and international advocacy called for a decade of action of road safety. And it's been 3 years now since it began, and much progress is being done with evidence-based interventions for reducing road deaths throughout the world. So I think a similar path should be taken, and we should bring and strengthen this discussion as countries in the UN General Assembly when this topic is brought up. Thank you.
Thanks very much, Arturo.
Please add pesticide to your alcohol and guns. Alcohol, guns, and pesticide. They all have big industries making a lot of money.
Closing the gap, guns, alcohol, and pesticides. Thanks, Michael. Valerie.
Yes, I mean, much of what I would say has already been said, and I will just move to a different part of the elephant, the same part that perhaps Devorah was on, and repeat what she said, that we know a lot more than we do about what we know. And my question is, what is the available fund of knowledge, and how do we make it accessible? Can we have a repository of information? Can we have this knowledge available in such a way that we can make multidisciplinary, interdisciplinary decisions, bring together the best of what we know from these various disciplines that are here, and have more integrated types of interventions that address the whole elephant, not just the tusk or the tail? Can we harmonize data or data systems? Are there ways in which the available data that we do have can talk to each other, be related? Can researchers who attack these issues from different perspectives have access to common data elements where they can mine these data? And we talked a lot about funding. And that's always a frustration for us. We fund in 5-year cycles for various types of projects, and when those projects are sunset, we don't always know how those projects are going to continue on, if there's any uptake, if there's any way to continue those. So some type of synergism in funding, leveraging the resources so that we can maximize the benefit of all of the good research that we've invested in.
Thanks, Valerie. I'm reminded in the field of IT, people talk about the necessity to have systems be interoperable. So you don't want one group developing a data system or phone system that can't communicate with the other, but this notion of interoperability for all of us as we work, we should be getting ideas, concepts, programs, policy, and research that's interoperable and shareable. Thanks. Francis.
Coming from the Office of Women's Health and having just attended the UN Commission on the Status of Women last year, in which I saw many countries come together to actually address violence against women, I'm still struck by the fact that all through the last 2 days, I did hear bits and pieces about resilience and how that does happen in families with mental illness. But I didn't see much research or much talk or discussion around efforts to reach out to families in the way that they dealt with family members, except on the panel in which the lived experience people talked about, how they felt about it. So I think if we start not just doing this as an individualistic thing, but the people come from families, they're in families, and there are some families that have had to deal with a lot of issues and the resilience in their family. What makes that work in that family, but not happen in another family, I think is a very key element of our discussions and our actions for the future.
Thanks, Francis. Vicki.
Part of what we've struggled with throughout the time we've been here is putting together the words mental illness, violence, and gun policies. And in struggling with that, initially I thought, oh, we're stigmatizing and stuff. But the more I've been in the meeting, the more I've been thinking about what our responsibilities probably should be, is that when we think about those three things, we need to be thinking about the number of people who commit suicide. We've been kind of thinking, I think, a little more on the side of people who have been, murdering other people instead of themselves. So I want to kind of put that as a major focus again, because that's where there's a large number of people that we could make a difference in their lives, in the sense of thinking about the gun violence relative to suicide. Along with that, we've also focused, and it's our nature as researchers, on diagnostic categories. And again, I'm going to kind of take us back to, and I appreciate everybody else that did, the issue of distress and stress. Because if you again, Ron Kessler's been quoted here several times, so let's quote him again in a sense of, there's a growing number of individuals who have sub-threshold disorders, and they don't necessarily merit yet an actual diagnosis. So with that being a growing number of people, with some of the impulsivity that we see that occurs in terms of some of this violence, it might also do us well to think in terms of our research of going beyond just holding on to our diagnostic categories, particularly given the changes we're going to see in terms of either DSM or RDoC or whatever it's going to be. Thank you.
Thanks, Vicki. I think we've gone around to forum members, and I want to give a chance for people who are in the Outer Banks who have a comment. So I see at least two, Peter, Josh, Ron, will come around, and everyone who wants. I only ask you, in view of the time, to keep it short.
Mark, thank you. Peter Donnelly from the University of St Andrews in Scotland. Can I just first congratulate all involved in what I think has been an outstanding meeting, both the quality of the contribution and the quality of the debate on what's really quite a difficult subject. Also, just to congratulate you on what I think is a very inclusive way you run these meetings. It's a tremendous privilege to be able to not only come as an observer, but to have the opportunity to talk to people at coffee time and indeed to make contributions like this. So thank you for all of that. My one suggestion really goes to the heart of the question that I think you posed, Mark, at the beginning of this session, around how we could actually change perceptions in terms of mental health and violence. And what I would suggest is that it has to be an active process, because the forces that are keeping it as it is at the minute are themselves active. It's the not very intelligent tabloid media. They're active all the time, and you have to counter them. So in order to show you what I think we should do, I need to draw an example from somewhere else briefly. So when we were trying to bring in...
It really has to be brief,
Okay,
Peter.
tobacco control legislation in Scotland, the industry said passive smoking is a nuisance. We said it's a killer. We did an advert where we had a woman who said, passive smoking's a nuisance, going to hospital's a nuisance, getting cancer is a nuisance, being dead is going to be a nuisance. And we ran it on the television, we changed the public's opinion, and we got the legislation through. And you need to do something really hard-hitting like that. So you need a series of adverts with figures, and you say something like, you show somebody in the street hearing voices speaking, and you say, Mark's no danger to you, but he may kill himself if he doesn't get help. And then you repeat this message, and you reframe it.
Thanks, Peter. I know you just picked a name at random. Where's Josh?
Right here, right here. All right. Thank you, Mark. Josh Horowitz with the Coalition to Stop Gun Violence. I'm also an adjunct. I teach public health advocacy at the Bloomberg School of Public Health at Johns Hopkins. This is a great meeting. I've learned a lot. We spent a lot of time today thinking about, in the last 2 days, what can we find upstream? That's what we do in the public health. We look how far upstream we can go. What are the indications of violence? But sometimes a problem gets downstream. In this world, the problem will always get downstream, despite our best intentions. And we've talked a lot about the 4% of interpersonal violence that has to do with mental illness. But we haven't talked necessarily about when. We talked about who and how to identify that. But we also know that there are times and when, the time continuum when people are definitely more risky. And that could be first episode psychosis. It could be an admission to an involuntary hospitalization or getting out of an involuntary hospitalization. It could be an ER visit. And I want to build on what James said. At those points, when we're all downstream and we know that there's an increased risk, the when of those risks, I think it's very important that we try to do all we can about and use the evidence that we know today. So we talked a lot about means, and I'll say the alcohol, the firearms, and the poison. But we know at times, like immediate post-hospitalization, that the means restrictions are incredibly important. That should go hand in hand with treatment, and we know those things work, and we should focus at those points on what we can do when the problem, when the problem has developed. Now, a lot of talk at this went into, well, what can we do? We have the NRA and we have the Second Amendment, et cetera. But if we think about it as when, then we can think about, for instance, a PTSD situation for someone coming back from Iraq or Afghanistan, then the possibility of means restrictions temporarily and treatment temporarily can go hand in hand with restoration. And if you think about the idea that there's a time-limited point on this and that people can get their rights back after they recover, the constitutional issues go away. And so I think we should think about means restrictions, treatment at a point, I think, when we know that when there's an increased risk of violence, I think we can create situations with evidence. I've worked with a group to produce this report, the Consortium for Risk-Based Firearm Policy, that talks about the times when you're at increased risk of violence. I commend the report to everybody. And I think if we do that, we can use the best research. We can stop both some suicide and some interpersonal violence, even though we'd like to be upstream. But sometimes we find ourselves downstream, and we shouldn't ignore what the evidence tells us at those times. So I would just commend that approach as well.
Thanks, Josh.
One area that has been touched on and alluded to that I would just like to highlight, and that has to do with early childhood interventions, and particularly around parenting. That addresses some of the childhood adversity issues. But moreover, there's evidence that has a salutary impact on mental illness. It has a positive impact on impulsivity and violence. And it has a positive impact on alcohol and substance abuse. So the things that we see as interacting to create a potential for violence are all things that can be addressed by dealing with parenting in the early infancy age. One last real quick suggestion, and that is that we need to not silo the treatment for addictions and violence and mental illness, and that there really needs to be, in various states, much more of an integration of those at various places. Thank you.
Thanks. Right in back.
Hi, I'm Julia Silva with APA. A person like me, I'm a disseminator and translator of research. So coming to a workshop like that is an opportunity to get, the state of art, what is going on in the area that I work on. And it's my passion, is what I do. And I think IOM does a tremendous job. I've been to most of the workshops for the past 2 or 3 years. And this is a wonderful thing that the Institute does, is put together you guys who produce research, knowledge that people like me use and disseminate to people, professionals in the world. So I think that is the primary goal and initiative for this kind of initiative. Second thing, I am very thrilled to see that when we learn things, when we put together knowledge, it makes us to feel like we needed to act on. And that's what I'm kind of getting here. Like, what can we do? We know more than what we do. Where can we go? What else can be done? I just wanted to caution, because there is a role for everybody, and there is a role for every institution and for every group. And also because there are so many others, thousands of people like me and organizations that are doing the work that you guys are talking about that we needed to do. And so my thinking is, how can we help to have thousands and thousands and millions more people like me? And that's maybe not a question for you. That is a question for other people. Other people like me, my association, other professional organizations, because that's an issue that we do every day at APA. How can we make psychologists more aware of the evidence-based practices, knowledges, and instruments so they can do an effective work at treating people? This is a question that we all share here in our different instances, in our different worlds. My suggestion would be that, the Institute does a tremendous job giving us the best on research. It would be wonderful, and I know that I've been talking to you about, how can we move forward in terms of the dissemination things? Who are the partners that the Institute can have to help disseminate what you guys do? And that's something that I would very much like, interested in being a partner of. Thank you.
Thanks, Judith.
Sina Fazell, Oxford. I just wanted to reiterate the importance maybe of secondary prevention. We're talking a lot about primary prevention, but if you look at populations with severe mental illness, so people with schizophrenia, bipolar disorder, event rates are really very, very high. Maybe up to a fifth to a quarter will experience an adverse outcome, including suicide, violent crime, or premature mortality. And therefore, interventions can be very highly effective because the event rates are so high. So we don't have this base rate problem that we do if we're looking at primary prevention or general population measures. So it's just a reminder. I think both obviously can go in parallel, but if you look at people with severe mental illness, it's remarkably high event rates and, remarkably good treatments. And here's a population that we can really make a big impact.
Thanks.
Longevity is 11 years shorter than the average person. So people with mental illness die on average 11 years earlier. And that's 11 years of life lost that could be prevented if they were appropriately treated and you prevented suicide and other activities.
Thanks, Michael. Patrick.
While I've greatly enjoyed being here, I do have concerns about the translatability of what it is that we know making sure that it gets to those people who are the doers. And my concern is that those who know and those who do, very seldom are they encompassed within the same individual. And so I'm wondering if there are ways in which the Institute of Medicine can reach out to either the National Governors Association, just within the United States, National Governors Association, or the National Association of State Mental Health Program Directors, where commissioners from across the country get together to talk about these broad healthcare, mental health, behavioral health care related issues. NAZADAD is as well for addictions, but there are opportunities where those who pull those levers and can really drive change at a state level all assemble. And I think it's important that those who know convey that same consistent message to those who do. And then secondly, that within those states, they all really need to have a lean event. Because what we know about social determinants of change is that economic security, access to stable housing, employment are usually housed in different silos within that state government. And when we try and file our taxes, go to DMV or do voter registration, each of those is a bureaucratic hassle for us. Imagine having a serious and persistent mental illness, having to apply for nutrition assistance, housing assistance, Social Security disability, getting connected with a mental health center or substance use provider. For them, that task is extraordinarily daunting, and so they often get missed. And so, we build state systems and expect people to walk to them. I think the government needs to do a better job of building systems that are easier for individuals to access the multitude of needs that they have.
Well, thanks. And this comes from someone who's in a position to know you're a doer and you're in charge of the whole behavioral health services for the state of Colorado. You don't just sell pot. I wanted to make that clear. But this comes from a position of doing. I want to first thank Short. Yep.
In response to that, which is, I'm a clinician, not a policy person, and I had an opportunity that took me to the policy level, and what I learned is that the policymakers rely on people like me, on people like you. They desperately want and need information to inform them. And since this is a national and international gathering, and I mentioned earlier that the National Conference of State Legislators had adopted this House resolution declaring youth violence a public health epidemic and calling for statewide trauma-informed education unanimously. There was no controversy. So right there is an opening for anyone in this group, for the Institute of Medicine, to make a connection through that, to begin to have a voice and to begin to give them the information that they need to help them take this to other levels. From what I've learned, resolutions bring things into awareness. It's not legislation, but it's the first step. And in Pennsylvania, that second step has been taken through the Democratic Policy Committee. But that's an opportunity in addition to the governor's group. There are over thousands of legislators, from what I was told, were gathered there, and they're open and they're interested.
Well, thanks.